Hey, this is Dr. Muthu. Welcome to Muthu Integrative. This is a wonderful opportunity that I wanted to share with you all about shared medical appointments brought to you by American College of Lifestyle Medicine. And I'm going to just share very small excerpts from this password protected video. So I want to respect the privacy of American College of Lifestyle Medicine. But the future of medicine is trying to get more number of people addressed at the same time and trying to save time and money for both the patients and the institution so that we can get all possible educational resources to the patient so that we empower the patient and give them the power to tackle symptoms amongst themselves. And they potentially can create a cohort of resources because now patients may actually know each other from group experiences and can share their experiences between themselves. So let's see what the coding and the billing logistics are from American College of Lifestyle Medicine, from various institutions that are already practicing this. Okay, let's see what they say.
With that, John, I'm going to kick it over to you to go ahead and start your stuff.
Thank you, Caitlin. I appreciate it. It's been really exciting to be a part of this of lifestyle medicine. And I recall in 2011, where in one of our early ACLM conferences, we had Edward Nossinger, and he presented shared medical appointments. He actually did a 4-hour workshop, and it really blew us all away. And I'm so glad we're able to share this because it's something based on evidence and lots of research, and we want to share some of that with you today. So next slide. Okay, shared medical appointments. These are group visits that are actually medical appointments in which multiple patients are seen simultaneously by the physician in a supportive group setting. That is, the focus is upon actual delivery of medical care. However, they also will bring a great deal of patient education, emotional support into the appointment by integrating help and support of other patients, as well as an entire multidisciplinary care delivery team into each patient's healthcare experience. So that's his definition. As you can see his reference down there of his book that was put out in 2009. But he describes the research from the drop-in group medical appointments and physical shared medical appointments, which is like a physical exam, in a group setting. That's new and novel. So what we're sharing with you today is, of course, the lifestyle medicine shared medical appointment. Next slide. Now, some people say, well, is that legal? Oh, certainly. In fact, you'll find lots of more information about the impact of what this can do. And here's just a statement from the American Academy of Family Practice that third-party payers should cover and pay for submitted evaluation and management services for shared medical appointments. And so this is one of the first things that your administrators will want to know is this something that we can do related to your current care processes. Next slide. Well, there's a lot of benefits from this, and this was, it really blew me away and everyone else, was the fact that so many things can happen from a shared medical appointment that it benefits healthcare, particularly from the patient's point of view. You can see from this list, there's lots of benefits. But from the patient's point of view, it really stands out that they have more access to healthcare. They are listened to because there's more time to spend with the healthcare provider, and it creates a higher patient satisfaction. And of course, the provider, they get to spend more time with the patient. They can, it actually increases their panel size so they can see more patients. So say maybe a provider is booked up for weeks and weeks and can't be seen, but when you have like a drop-in shared medical appointment, they can pop right in anytime during that week when they have one of those group classes. So I mean, it creates a much higher work satisfaction when you can do shared medical appointments, and particularly as it relates to lifestyle medicine. Next slide.
So here you see beautifully how the current situation that we are facing in America, or probably world over, is the waiting time for patients before they can get to see a physician, whether it's a new patient visit or a routine follow-up visit. But this is not just in lifestyle medicine, but in regular family medicine care or internal medicine care or pulmonary specialty care. Most importantly, this was started by Dean Ornish and some of his peers during the times of the year 2000 and onwards, where cardiac rehab and intensive lifestyle therapy was one of the first opportunities where this was explored. And this has already been explored in other countries in different forms. Bariatric surgery is one example for that. So sky's the limit, right? So it's up to you how you talk to your institution and try to see if we can make this happen, and trying to see if, what the billing and the coding is so that we can get the best out of this. Let's keep going.
So who can do this? Well, any credentialed provider can do shared medical appointments. And it doesn't include just, we as dietitians and health educators, we are getting referrals from medical clinics, from primary care providers who's actually assessed that patient and has, they have identified the risk factors and chronic disease situations that each person has. And so what we first do is we bring them into a lifestyle medicine SMA or a curriculum that deals with lifestyle medicine. And I'll show you that in a second. And then that may be multiple times during the week for several weeks. And then it's followed up by a supportive SMA, supportive lifestyle medicine visits maybe once or twice a month. And that's carried on throughout the year, where it follows the care plan of that individual, and then annually we renew that. So it kind of gives you an outline of how we're using it and how it can be used in a primary care practice. Next slide. Now, of course, the content, that curriculum you're going to use to deliver that, particularly the phase 1 portion, 6 pillars of lifestyle medicine. And in fact, you could intersperse these different topics of condition specific to one of the 6 pillars and create a curriculum that really focuses and creates an intensive therapeutic lifestyle change intervention. Next slide. All right, here's the format. This is the structure of how to do it. And you'll see more as we go and as Fatima just shares her experience. But first of all is getting that leadership support. You'll find from some of the references and that we share with you here that this can definitely be a financial benefit and a support for the whole staff, and of course improve patient outcomes. But first, determine your target audience of your for your visit, your group visit, and what size you want to be at. Let's say 10 to 15. That's fine. At some groups, 8, but it's what size your space allows. You want to outline that curriculum like I described. You want to have a space that is something that can be part of your practice. So if you don't have an actual space in your facility, then you're going to have to recruit another space, but that space has to be on your practice, where you practice in your credentialing papers. Then you can market it to your target audience, you deliver that SMA, you collect appropriate data, which is a variety of both hard and soft data, and you have educational tools and resources you'll share with patients. And then, of course, documenting is important. And having a good EMR to help easily document these things is helpful. But most importantly, of course, is that the billing is correct and it fits you as a provider and who you are. So go ahead and next slide. Okay, here's just some lists of tools and resources that you need to, you can have available, like the consent form. For example, before you start one of these, you want to have a consent form. You want everything to be HIPAA compliant, and That's part of this consent. But other resources, handouts, books, cookbooks, variety of things like that, having a space where you have a whiteboard and educational tools, projector, or video, this type of thing is important. Of course, having the appropriate staff. Next slide. Now, not everybody's going to be wanting to do this. I mean, some people are embarrassed. They don't want to go to share their own medical history and things like that. In fact, there was one story of a group. It was a shared medical appointment for rectal exams for men, prostate exams. And that's exactly right. That was the SMA. And it was 10 men that met together, and one wanted to bring their wife. The wife wanted to come. They thought that would be kind of uncomfortable for people, but no one dropped out as a result when they were informed. And they did it. But there may be other constraints that hold you back from doing it, but if you can do a shared medical appointment, especially a lifestyle one, do it. It's going to pay off. Go next slide. Let's look at the coding. So right now we've been focusing on SMA traditionally been focused on using E&M codes, and these are of course providers such as the physicians and the nurse practitioners and PAs. They would use these codes, and each patient visit is represented by the appropriate code. In most cases, it's like a 993213, but you would make that decision based on the complexity of the visit. So if you mark that, though, a modifier 33, then that would mean this was a preventive care visit and would not be subject to copays and deductibles. Now, we've moved into virtual scenarios now, and so there's a little bit different with modifier 95, and location is still 11, which is the office, even though no one's actually in that office necessarily. That's how we're coding it now. In fact, in 2021, we're going to see many more new requirements for E&M codes, different changes. So they're listed here. But what's interesting is that when you do a virtual one visit, then it's basically going to be one of these two, time and MDM, or medical decision making. It's really going to be two things that you can utilize anyway. So let's go to the next slide. All right, now there's group codes too that physicians can use and other health professionals, such as dietitians, behavioral health specialists. These are like 99412, which means 1 hour, they're time-based, 1 hour visit. 97804, that's the 30-minute group visit. And this includes, these are all preventive care or nutrition therapy type of codes, or psychotherapy code. And again, you can still use these based on the time of the visit. It's considered as a group, so it's just how long the group is. So a 90-minute session would be, in terms of 99412, would be actually be 2 units, because it's an hour and a half, at least half of the unit, and it goes to the 2 units. And for 97804, because it's 30 minutes, that would be a 3-unit visit. And again, the same kind of criteria for virtual is that you have 95. But in the normal arrangement of things, we would use a 2, because without public health emergency, which means telehealth. Okay, next. Now, billing, you actually do the billing. We want to follow regular compliance reviews and checking your paperwork. And I'm sure you have billing people that will do that for you. If you don't, that's something you got to do yourself. But make sure that it's compliant with what you're actually did. The codes represent what you actually delivered. Next. Now, I'm going to share with you a little bit about what we do. And these are medical nutrition therapy codes. And here we have 97802 is actually an initial visit. That's an individual visit, followed by the 97803, which is a follow-up individual visit. And then we also have the group visits, which is what we use for our lifestyle medicine groups. And that's 97804. And those are CPT codes that are like utilized for Medicare and commercial health plans. We also have the S9470, which is visit with a dietitian. That's also used. But when in Medicare, when you reach the limit of 97804, you switch to G0271, carry on with the number of more group visits that year. Okay, next slide. Here you see, I just took the month of July, so you can see what we've done in July. And these are the numbers of visits, and there's 86 visits that were actual group visits. You can see the distribution of the payers. We have more commercial than anything else, but this gives you an idea of what our small little practice does. Go ahead and next slide. And you can see what kind of reimbursement that is. So for example, even though it's, these are just what it is per hour when you bill an individual session for each person. Next one. Now, all these CPT codes need to be paired with an appropriate ICD-10 code, and this gives you a list of for instance, this is coming from United Healthcare and their preventive care guidelines as to what type of diagnosis code would be appropriate with a preventive care code in a group session. And you can see it hits a lot of areas, very open. Next slide. All right, now I want to just give you the economics behind this and compare a group visit with 15 individuals compared to individually seeing 15 people. So you can see here the total time makes a big difference. We're doing 90 minutes to see 15 people versus 225 minutes to do a 15-minute visit, 99213. And so these reimbursement rates, $130, that's basically what comes out of the National Fee Analyzer at 50 percentile. Yours may be less, maybe more, but this just gives you a ballpark so you can see the difference. And it comes out to, in this case, about the same, which is different. But look at the time difference, 3.5 hours, 3.75 hours compared to 1.5 hours. That gives you quite a significant increase in the efficiency or how much you get per hour when you do 15 people. But it comes down to the break-even point of 6 patients. So if you have 6 patients in a group, you'd make the same per hour as you would being the 15 per hour, any individual per hour. So next slide. So I want to show you here, this was the preventive care code, and that same relationship is there. You see the bottom line there, $1,040 per hour compared to $200 per hour when you do preventive care. And again, that's another reason why we want to do preventive care as much as we can in groups, because it's more cost effective, especially as a physician or nurse practitioner, you're going to do better in groups than individually. Next. All right, so 2020, we were thrown into the COVID-19 crisis, and we just finished our group session in April or March, where we just finished our major group session and then immediately transitioned to virtual. And this was quite a jump. We fortunately anticipated this because I saw the benefits of doing a virtual SMA and said, hey, I don't even need additional offices, because we had classrooms over in the state of Washington as well as in the state of Oregon, because we were only across the river. And I had office over there in Vancouver, Washington. And we said, well, let's close that so that in 2020, we can do all our groups from one location and have they can be virtual. Because in 2020, Medicare Advantage is now allowed to do nutrition and lifestyle counseling over particularly medical nutrition therapy over the virtual, telehealth without having to be in a rural area. And that's new for 2020. But then when COVID hit, everybody gets it regardless of that regulation. And so why? Because look at it, it helps to keep people from getting sick. They can be safe at home. And these are another more benefits of lifestyle medicine virtually. Next slide. Okay, and there's a lot of changes that coming in 2021. And so these are some of them in the sense that, and through this COVID-19 situation, we have, for instance, that second bullet point, the telephone calls. You can be talking to somebody on the phone and you would code 99441, or they might be on the phone in your group visit and not on a telemedicine, and you would use one of those kinds of codes. And that's paying the same as an E&M code. If you're doing E&M codes, that's comparison. But again, you would use 95, and of course, all the things that you do, you want to be consistent in terms of your policies. So this is, I think this is the end of this series for me, and I want to pass this off to Padmaja, and she can tell you about her experience. Thank you so much.
Thank you, John, for giving us such an in-depth understanding of shared medical appointments. Now I'm going to focus on how to apply that information in your clinical practice. Next slide, please. We have been using lifestyle medicine shared medical appointment as an intensive therapeutic lifestyle program for diabetes reversal. We started our first group with 12 participants in February 2020. We had to put our program on hold in mid-March because of COVID-19 pandemic. Thankfully, I was able to convince our leadership about moving this group visits on a virtual platform. We started our first virtual lifestyle medicine shared appointments in May via using Zoom paid accounts, which are HIPAA compliant. We've completed 5 groups so far since May, and I started 2 new groups this week, 1 in person and 1 virtual. Next one, please. Before they get enrolled into group visits, they will have 3 visits with a physician during this 3-month program. We obtain hemoglobin A1C and fasting lipid profile before that are prescribed by at each time they have a visit with physician. During COVID-19 pandemic, next examination. Next one, please. The question that American Academy of Family Physicians asked Medicare, and their response was that under existing CPT codes and Medicare rules, a physician could furnish a medically necessary face-to-face E&M visit to a patient that is observed by other patients. So for 99213, from a payment perspective, there is no prohibition on group members observing while a physician provides a service to another beneficiary and the examination to bill for them. Our typical in-person shared medical appointments are 2-hour longs, whereas virtual ones, we keep it 1 hour long. A health coach who is an RN reach out to patient before each group visit. It's also important to make sure that participants feel comfortable using technology and have them a visit demo before act. So I think the most important thing is to remember having telehealth consent, which is a little different chemistry of the group so that they can connect with each other. And it also gives them this informal time to get to know each other. Next one, please. Resources and tools that we have them to make better choices every time they're eating out. We also make sure health coach is addressing 6 pillars of lifestyle medicine during her time with them. In addition, we have like 6-2, which is a 30-minute limit. And if they're spending 1 hour, we use 2 units. For labs, we will hemoglobin A1C and fasting lipid profile for at the beginning and at the end of the program. Next one, please. So the key is.
Okay. So I'm hoping that was a good intro to all of you regarding some basic aspects of shared medical appointments. You call it intensive lifestyle therapy. You can call it as an outgrowth of cardiac rehab, started by the Association of Pulmonary and Cardiac Rehabilitation. So whatever umbrella this can come under, the ultimate goal is to try to make the patient-physician contact more efficient. Right? So welcome to Muthu Integrative, and I hope you will find more videos on this channel that are very useful in your own practice and in your own health. And please do let me know if you have any questions. Thank you for joining us.